Thank you very much. At the outset, I would like to thank the organizers, Professor Dhiman and team, SGPGI and AIMS, and for organizing this session. My job is to speak on diagnosis and management of sepsis in patients with ACLF, and I bring greetings from PGI Chandigarh. ACLF, as you know, is a state of organ dysfunctions, immune dysfunction, and multi-organ failures where mortality is an endpoint in majority of patients around 50%. And the management of sepsis in these patients is art and science where both meet together. So I'll be taking you through the concept of sepsis, definitions, pathophysiology, pillars of management, and take-home messages. So briefly, what is sepsis? Sepsis is basically a dysregulated immune response to an infection followed by organ failures and organ dysfunctions characterized by rise in SOFA scores by more than or equal to 2 points. And the infections are defined by breach in barriers and which incites the local and systemic inflammation, which leads to clinically apparent symptoms. Typically, infection is defined as bacteremia, followed by systemic inflammation in terms of fever and leukocytosis, followed by shock and mechanical ventilation, which defines organ failures and sepsis. The definition of sepsis has evolved over the time. Initially, it used to be defined as SIRS to infective organism, followed by an Impaired model where the predisposition injury responds to that injury, that is the pathogen, followed by the organ failures. But this definition was too cumbersome, so it was redefined in 2020 that there was a rise in SOFA scores to an infective trigger followed by immune dysregulation. And this definition was defined as sepsis 3 definition of sepsis. So how common is sepsis in patients with ACLF and why patients with ACLF are prone to infections? So there is immune dysregulation, which is ongoing in patients with ACLF. And in a continuum, as a continuum in patients with cirrhosis, there is cirrhosis-associated immune dysfunction, which leads to innate and adaptive dysfunction. And in patients with ACLF, there is a plethora of literature which suggests that there is an immune paralysis, upregulation of HLA-DR, and a lot of immune dysregulation such as T regulatory cells, myeloid-derived suppressor cells, they increase. And in patients with ACLF, they are in a state of immune dysregulation. So these patients are prone to infections. And in this study by Dr. Shalimar, they showed that infections are quite common in patients with ACLF, close to 10% at diagnosis of ACLF, and on follow-up, 73% of them develop infections. Patients who develop infection at diagnosis or at follow-up, they have a high mortality, close to 75%. And patients with ACLF, there is an increasing probability of infections during the hospital admission. So why these patients develop sepsis when they get infected? So there is basically a concept of impaired tolerance to infection, which leads to sepsis. There is a dysregulated iron metabolism where a lot of infective cytokines leads to hemolysis, which releases the heme, which causes the free radical generation, dysregulated ferritin, which increases, and there is an impaired hepatic gluconeogenesis and mitochondrial dysfunction, which impairs the immune response to infections. And clinical correlates of infections which progress on to develop ACLF include the SBPs and the pneumonias and the nosocomial infection and ineffective antibiotics. And these patients who develop such infections and they get ineffective antibiotics, they progress on to develop multi-organ failures and ACLF. The 3 key components which are altered in patients with sepsis and ACLF include dysregulated inflammation, increased portal hypertension, and organ maladaptation in terms of immunometabolic failure, which progresses on to develop multi-organ failures and mortality. Despite decades of research and improvement in critical care, the mortality of sepsis patients remains high in patients with cirrhosis. And this is predominantly because of increasing risk of MDROs over the last few years. Because MDRO infections, multi-drug resistant organism infections, are associated with lower resolution of infection, higher incidence of septic shock and ACLF, and higher short-term mortality. The pillars of sepsis management in patients with ACLF include the early diagnosis and treatment of infections, appropriate management with fluids and maintenance of intravascular volume status, use of vasopressors, timely use of vasopressors, and adequate nutrition. So regarding the early appropriate treatment of antibiotics, in a PREDICT study, they showed that in patients with acute decompensation or patients with ACLF, if they receive adequate antibiotics, the survival is much better as opposed to patients who receive inadequate antibiotics. And each hour delay in appropriate antibiotic increases the risk of death in patients with SBP with septic shock by 1.8 times. Importantly, in this study where they showed that in ABT, which was published in 2015, that patients who had a very high Apache score, that is 30 or above, the mortality was persistently high even if you use the early and appropriate antibiotics. So the idea is to treat the patients early on before they get into multi-organ failures. So when do you suspect infections in patients with ACLF? The most important thing is the worsening of organ dysfunction, which means that there is a worsening of ascites, HE, or new onset of organ failures, or if they develop renal failure or worsening of ascites. Additional risk factors which you have to consider in history is the travel to endemic area, prior contact with the healthcare facility, invasive procedures, antibiotic prophylaxis, and prior episodes of SBP. And definitely you need to examine that patient for defining and identifying the source of infection. Typically, the working definition of infections have been proposed by EASL and as well as ASLD societies. And we all know that what is SBP is a ANC count of more than 250, UTI as one symptom or sign with positive urinary culture, or at least two symptoms or sign in presence of significant pus cells in the urine, which is more than 10 per high raised to power field. Pneumonia is defined by at least three findings: imaging findings showing progressive or the new onset infiltrates, local sign and symptoms in forms of cough, sputum, increased sputum, and systemic sign in form of systemic inflammatory response, that is fever, leukocytosis, leukopenia, or altered mental status. So all three of them have to be present to make a diagnosis of pneumonia. And for bloodstream infection, it is if the single blood culture is positive for a non-common skin contaminant, that is non-staph species, and two blood cultures consecutively positive if there is a skin contaminant. So minimum workup for infections with which one should perform in patients who are admitted in hospital with acute or chronic liver failure, and all of them should be considered infected until proven otherwise, as proposed by EASL. Every patient should undergo a complete hemogram, urinary microscopy, ascitic fluid workup, cultures for blood, urine, and ascitic fluid, because these patients are in organ dysfunction and state of organ failure, so every patient should be considered to be infected. Radiography of suspected site of infection. Biomarker, especially procalcitonin, has been found to be useful in guiding the treatment as well as de-escalating the treatment, as we'll be seeing in subsequent slides. Blood gases with lactate needs to be examined in all patients because lactate clearance and levels of lactate have been shown to be associated with poor outcomes and the mortality in patients with ACLF. And the use of rectal and nasal swabs I'll be discussing in subsequent slides. So what are the factors which govern or guide the antimicrobial choice in patients with liver failure? Broadly, they are classified into pathogen, host, and environment-related factors. The most important of these include the severity of infection and the setting of infection, which also includes the risk of MDROs. So two most important factors, that is the severity and the setting. So regarding this local epidemiology, which is utmost important in guiding the management of patients who are not having septic shock, includes the local epidemiology, and we need to understand this in this global study, which was published in Gastroenterology 2019, where India has the maximum number of patients. There they showed that the prevalence of infections in patients with cirrhosis admitted in hospital was close to 50%, and in patients with ACLF, it was 66%. The MDRO infections were quite common out of all culture positive infections, which was 70%. And most of these infections were nosocomial in patients who were having MDRO infections. And if we closely look at the distribution of MDRO organisms in patients with cirrhosis in India, we see that carbapenem-resistant infections, including CREs, carbapenem-resistant Enterobacteriaceae, that is E. coli and Klebsiella, or Acinetobacter, are quite common as opposed to MRSA, and Enterococci, which Western countries and American countries have shown to be significantly high as opposed to in Indian setting. The sensitivity to antibiotics in healthcare associated infections and nosocomial infection has shown to be quite poor in Asian countries as opposed to the other countries. So there they have shown that the resistance to carbapenem in patients who acquire healthcare associated infection and nosocomial infection is close to 60%. Different biomarkers have been described in literature for diagnosing infections in patients with cirrhosis. And I have just summarized all of them in 2 slides that CRP can be used as a marker for, good marker for ruling out an infection. Although the positive predictive value is quite poor, it is an inflammatory marker, and it is quite also falsely negative in around 15% of individuals. Procalcitonin has been found to be useful for diagnosing, ruling in the infection, guiding the management, escalation of management, and de-escalation of management also. And we need to understand that the levels of procalcitonin changes with respect to the liver dysfunction. And according to one study where they showed that when the bilirubin levels rose above 5 milligram per deciliter, the cutoff levels for defining infections went up. And in patients with bilirubin more than 20, which we usually see in patients with ACLF, the cutoff for defining infections are procalcitonin of 0.94 with an area under curve of 90%. And if we combine procalcitonin in CRP, we get a better sensitivity, but by 10%, but the negative predictive value also increases by 5%, but the combined use is still debatable, and there is lack of literature, especially in patients with ACLF, as to using combination of procalcitonin in CRP. Recently, then an emerging data of cleaved segments of CD40 in the plasma, which is also called pre-sepsin, and they have shown that cutoff above 1600 can be used for ruling in the diagnosis of the infections in ACLF. But it has been shown in subsequent studies that it is not superior to procalcitonin, at least statistically. RT-PCR and the molecular tests for diagnosis of infections are also emerging. They also include that the particular bacterial DNA and their sequencing can be done using advanced techniques such as nanopore sequencing, but predominantly these are affected by environmental contamination, lack of standardization, and lack of validation in patients with ACLF. There are a lot of emerging biomarkers, including CD biomarkers of monocyte and macrophage activation, TREM1. However, they lack validation in patients with acute and chronic liver failure. There are emerging data about neutrophilic mobility in the microfluidics-based diagnosis of infections. Again, recent studies, but there is lack of validation. And monocyte distribution width are also an emerging markers for infections. We also showed in a proteomic-based panel and recently validated that information in patients with ACLF that a model, which is called PACIFY model, it predicted the infections in patients with ACLF by 95% accuracy. But real world, there are a lot of challenges in making diagnosis of infections, lot of confounders, and organ failures per se because of ACLF can confound the diagnosis of sepsis. So how to approach? The European Society have recommended use of sepsis 3 and Q-SOFA criteria. And the sepsis 3 or Q-SOFA, any 2 of them is positive or both of them are positive, then the patient are considered high risk of mortality, and these patients should be shifted to ICU. If both are negative, they have a good outcome, and these patients should be managed as outpatients. And any of them is positive, then case-to-case basis decision should be taken for care of management. We recently proposed an algorithm that showed that the risk of infection, the severity of infection needs to be seen. If there is a presence of shock, straight away carbapenem plus minus gram positive color, depending upon the risk factors. And if there is no shock or risk of MDRO, then we need to identify the source of infection. And depending upon the source of infection, SBP, UTI, pneumonia, or skin soft tissue infection, the proper guidelines have been recommended by EASL, but things which are very, very important include if there is an SBP which is community acquired and the Cliff SOFA score is more than 7, one should not use cephalosporin because it has got higher mortality compared to piperacillin tazobactam in one of the Chinese studies. Importantly, for patients with pneumonias, we need to understand the local epidemiology, and the nosocomial pneumonias merit colistin combination or ceftazidime avibactam combination therapies. Prolonged infusion of antibiotics have shown to be superior as opposed to intermittent infusions of antibiotics. So this is a take-home point that infusion of broad-spectrum antibiotics, carbapenem, imipenem, should be given as an infusion. High-dose antibiotics in initial 48 hours have shown may be superior because it abrogates the mutagenic window and where the resistance develops in the patient, the pathogens. Patients who are culture negative at 48 to 72 hours, we need to reassess, and whether these patients have culture positivity, we have to adjust the antibiotics according to the cultures. But if they are culture negative, which happens in 70% of individuals, we can take help of MDRO rectal swabs. And these rectal swabs, if the patient is an MDRO colonizer, it increases the risk of MDRO infections. We also showed in a recent study that MDRO colonization is quite common in patients with cirrhosis admitted in ICU, and they led to the increase in risk of MDRO infections, and they also led to increased mortality who were colonized at multiple sites. Then there are culture-driven management, and it is clearly shown that ESBL producing organisms are carbapenem is the treatment of choice. For CREs, it is the CAV-AV. For Acinetobacter, it is the colistin with tigecycline. And for MRSA, it is the Vanco or the TICO. And for the VREs, it is the linezolate or the tigecycline. I'll be skipping the prevention of MDROs, novel treatment options. Just one point about the fluids and vasopressors, that the patients who are in hypotension need 5% albumin for fluid resuscitation because that has shown to improve the survival at 1 week. 20% albumin improves the hypotension, but the adverse events are quite high, and appropriate calories and proteins are recommended in patients with sepsis so that they improve the systemic inflammation, endotoxemia, and sepsis. In fungal infections, I'll be skipping. So take-home messages from this talk include that the cornerstone of management of sepsis includes the early identification and the prompt institution of antibiotics that improves the outcome of patients with sepsis in ACLF. Adequate culture should be sent before starting an empirical antibiotics. Initial resuscitation should be based on surviving sepsis protocol, which is 1 hour. We need to start the vasopressors, the fluids and the vasopressors, and stop the counterproductive drugs, especially PPIs, NSAIDs, beta blockers. And de-escalation approach is safe and recommended, should be performed. And every 48 to 72 hours, patients should be reassessed for de-escalating the patients from antibiotics, broad spectrum antibiotics, using the stewardship principles. Thank you very much for the patient listening. Thank you.